Welcome to AETCM, the emergency medicine channel. Shall we start? A 48-year-old female who is a known case of left vestibular schwannoma post-resection 2 weeks back before presenting to our hospital, presented with complaints of fever and cough with expectoration associated with worsening of breathlessness since 5 days. So, coming to initial 10-second assessment, airway was patent, no pooling of secretion. Patient was able to complete one full sentence. Coming to breathing, respiratory rate was 45 per minute. Saturation 94% on room air, and bilaterally
what
there
is the
were
normal respiratory rate?
16 to 18.
Okay.
Saturation was 94% on room air. There were
The
bilateral.
saturation is normal, but respiratory rate is very high. How do you explain that?
Because of hypoxia, the patient may be in means increasing the respiratory rate to.
Okay. So first response of hypoxemia is tachypnea.
Bilaterally, there were CREPs and V's. So initially, we started with nebulizations with salbutamol and ipratropium bromide, one after another with oxygen, so that the saturation was.
How do you know that it is not stridor?
It will be.
What is the difference between stridor and V's? Because schwannoma operation is done, 9th and 10th cranial nerves can be compromised, patient can have aspiration. Stridor is very common thing. How do you know that it is not stridor? What is the difference? We don't know whether it is upper or lower.
Inspiratory sound is
Stridor is inspiratory and expiratory. It is fixed. There is no change. Whatever, whether you change your position, sitting, standing, coughing, it will not change. Whereas V's depends on your position, coughing, everything it will change. And it is polyphonic. Other one is monophonic. Okay. Because stridor is one of the common problem in post surgery in brainstem and patient who is having malignancies. That is very common here. So unnecessarily giving nebulization may not improve the condition. Even patient can have adverse effects.
Coming to circulation, BP was 130/78 millimeters of mercury, and pulse rate was 129 per minute. And disability GCS was E4 V5 M6, and patient exposure temperature was 102.
What are the reasons for tachycardia here?
Tachypnea, hypoxia.
Hypoxia itself is a cause.
And nebulization.
Nebulization is other cause. Okay.
Then temperature was 102 degree Fahrenheit, and we have given paracetamol 1 gram IV stat. Coming to sample history, a 48-year-old female who is a known case of left vestibular schwannoma post left retrosigmoid craniotomy and excision of the CP angle mass lesion 2 weeks back before coming to on the presentation to ER, and she was on steroids.
Common findings of CP angle tumors. Common findings. This patient can come here as a first time patient also.
Vertigo.
Huh?
Hearing loss,
Hearing loss,
tinnitus.
okay. Initially vertigo, tinnitus, vertigo, and
Hearing
it
loss.
may sometimes create hearing loss. Okay.
She was on steroids for 5 days post discharge, and after that, after 2 days, she was having fever with cough and expectoration for 5 days with worsening of dyspnea. There was no history of any chest pain.
So was she intubated during that surgery?
Yes.
Is it important?
Yes. Ventilator associated pneumonia can happen.
It is very important because if the patient had a history of intubation 1 week back, if gag reflex is normal and if he had a history of intubation 1 week back prior to that, there is a high chance of ventilator associated pneumonia in this patient.
There was no history of any pleuritic chest pain or central chest pain, orthopnea, PND, any vomiting, loose stools, or altered mental status. So initially, we had started with nebulizations with oxygen, and we had taken an ABG before starting oxygen. So pH was 7.519, PCO2 was 29.
7.5.
Yeah, 7.5. PCO2 was 29.9, PO2 was 58, lactate was 2.3, and bicarbonate was 24.2, which is showing respiratory alkalosis because of tachypnea.
Why lactate is increased?
Because of the respiratory distress.
Distress and hypoxia.
So there was a type 1 respiratory failure. So we had started.
Is it compensated?
Yes, PCO2.
PCO2.
Washout is there.
Washout is there.
So initial state of hypoxia because of respiratory distress, and then it will come to type 2.
Type 2. Then only it will become common. So you should immediately tell there is no time. It is not a chronic problem. It's an acute problem. Time has not come.
And we had sent CBC CRP point of care showing WBC count of 11.5, platelet 264, CRP was 88.7 and hemoglobin 12.1. So with oxygen mask also patient was, the respiratory rate was 40 per minute. So we had changed the patient to BiPAP. And then she was with a FiO2 of 30%, 10:5 pressure. So tidal volume was achieving around 345 with a minute ventilation of 7 liters per minute and was maintaining saturation. And in view of recent hospital admission, we had started on piperacillin tazobactam with an azithromycin. And
what is the difference between piperacillin tazobactam and azithromycin? It all same or different?
Piptas can like gram positive and gram negative coverage is there.
Azithromycin.
Mainly for typical gram positive coverage is also.
It's a good gram positive coverage.
Atypical.
Atypical. We are covering for atypical. That doesn't. The piperacillin tazobactam doesn't cover atypical like azithromycin or levofloxacin or doxycycline.
Then ECG was showing sinus tachycardia with no STT changes, and we had taken a chest X-ray showing a right-sided right lower zone haziness. So
when you get a right lower zone haziness, commenting on right lower zone haziness will be enough sometimes. What other things also you will comment when you are going for an exam? Right lower zone haziness, it's a general term, right lower zone haziness. It can be in pleural effusion, it can be in collapse, it can be in consolidation, it can be in tumor, it can be diaphragmatic elevation. So what
mediastinal shift is there or not?
How do you express all these things? So once you tell the finding, I should get, or examiner should get an idea that okay, this is not collapse. What is that?
There is no mediastinal shift.
There is no lower mediastinal shift. There is no diaphragmatic elevation. There is no crowding of ribs. These three things you are supposed to tell. Then the person who is examining will come to know that okay, there is no collapse. Collapse is very important. Comparing to all other things are volume expanding lesion. Collapse is a volume reducing lesion.
So we had sent for further investigations like procalcitonin. It came out to be like 5. So we had continued with piperacillin. We had admitted in ICU, started on piperacillin tazobactam with azithromycin.
What is the gag reflex in this patient? Should we do it or?
Yes, because suspecting aspiration pneumonia. Because
Why?
of the right lower zone, there is.
Why you are suspecting?
X-ray was showing right lower zone.
No, that's okay. We are suspecting aspiration.
Post schwannoma.
Post schwannoma is 8th cranial now, no?
9.
Just near to that 9th and 10th, because when we write the diagram, it may be here, 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 but in the brainstem, it is a very small space. 9th and 10th are very, very near, maybe half centimeter or quarter centimeter. So 9th, 8th cranial surgery can even involve, because of the edema, they may not touch the center, but the edema will be there. That edema can press the 9th and 10th. The transiently patient can have dysfunction. That's why they have started steroid. Okay.
And then we had taken a CT chest with showing multiple centrilobular ground glass nodules scattered in both lung parenchyma with confluent areas in anterior basal and lateral basal segments of right lower.
So you think it is aspiration pneumonia or something else?
Since it is both lung.
Bilaterally, patient had history of intubation. Do you suspect simple aspiration pneumonia or something else?
Like healthcare
It can be mostly. We have to suspect a hospital acquired infection in this patient. Viral pneumonia is also possible. Okay.
And then we had in CT there were like a tree in bud appearance. Okay. So suspicion of TB was also there.
Tree in bud can be there in many types of pneumonia, but if you have long-standing symptoms, then TB is the strong possibility.
So we had given a consultation for respiratory medicine for bronchoscopy and BAL taking. So bronchoscopy samples were sent. There were no presence of any TB, and they also
presence of TB or something. What is the test you do?
Gene expert.
Gene expert.
And then the gram smear was showing only inflammatory cells.
What is the difference between gene expert and other type of TB test? PCR is one test. Gene expert is another test. AFB culture is another test. What is the difference between all these things? Culture will take 6 weeks. LJ medium culture, it takes longer time. PCR is fast. You get in 1 or 2 days. Gene expert? Gene expert is a test which
genes
expresses
can
the gene of that bacteria with resistance.
Can be found.
So you can know first line drugs are resistant or not. Rifampicin and INH. That is the importance of gene expert. Okay.
So with BiPAP, she was maintaining saturation and PaO2 was also maintaining. So with the current antibiotic, she was improving, and then she was discharged.
Okay.
So coming to the initial evaluation of treatment of pneumonia, mainly community acquired pneumonia without any immunocompromising condition. So the diagnosis is made by first when there is a newly recognized pulmonary infiltrate in lung with one or more respiratory symptom with at least one other signs or symptom. That is, respiratory symptoms are new or increased cough, new or increased sputum production, dyspnea, pleuritic chest pain. And other signs and findings are abnormal lung sounds, fever, leukocytosis or unexplained bandemia, and hypoxia less than 90%. So if it is there, whether there is hypoxia or criteria for admission is there. If it is not there, we can discharge the patient. If there is, if the patient is admitted, we have to see for the community acquired pneumonia severity. For that, we can find like there is two major criteria and multiple minor criteria. There should be one major or two or more minor criteria. The major criteria are one, septic shock with need for vasopressin and respiratory failure requiring mechanical ventilation. That is two major criteria. And other minor criteria are respiratory rate more than 30, PaO2 FiO2 ratio less than 250, multilobar infiltrates, confusion, disorientation, uremia, leukopenia, thrombocytopenia, hypothermia or hypotension.
Is it pneumonia severity index or something else? What is the
This is IDSA guidelines.
IDSA guideline?
IDSA guidelines. So if the CAP severity is non-severe, we have to test for other viral markers like procalcitonin, blood cultures, everything. If it is positive, we can proceed with viral oseltamivir treatment. And if it is not there, we have to see for MRSA or non-severe CAP risk factors like MRSA colonization or infection of the respiratory tract. If it is there, we have to give for MRSA coverage. If it is not there,
What
we
is MRSA coverage?
vancomycin.
Venous audit, vancomycin.
If it is not there, we have to see for Pseudomonas aeruginosa non-severe CAP risk factor like advanced structural lung diseases
What
or
is the coverage of Pseudomonas?
with piperacillin and tazobactam
And it's always dual drug therapy.
with
You can
macrolide.
give single drug, but it has to be
With
dual drug.
macrolide can
Macrolide. Pseudomonas.
topramycin.
Tobramycin or levofloxacin, quinolones. Okay.
So if it is not there, we can go with beta-lactam with macrolide or respiratory fluoroquinolones. If the CAP severity is
What are respiratory fluoroquinolones?
levofloxacin, moxifloxacin,
Ciprofloxacin?
can both used for
Cannot be. It is not respiratory quinolone. It's abdominal quinolone. Okay.
if the CAP severity is severe, again test for viral diagnostics, and if it is not there, if it's viral diagnostic is positive, go for viral
What are the
antiviral
most
therapy.
common organism which produce CAP? Community acquired pneumonia.
Streptococcus.
Streptococcus. Staph is not there. Staph can be
And
there.
virus.
Streptococcus.
Virus.
Viruses. Okay.
And
H influenza. H1N1. COVID.
COVID.
All these things.
If CAP severity is severe also, if it is viral markers are negative, look for MRSA coverage, and if it is not there, go for Pseudomonas aeruginosa. So coming to antibiotic, like in standard regimen for non-severe CAP is a beta-lactam antibiotic with an atypical with a atypical coverage, that is macrolides. So either we can choose ampicillin, ceftriaxone, cefotaxime with azithromycin, clarithromycin or doxycycline. And if we want MRSA, even MRSA coverage, vancomycin or linezolid, or beta-lactam along with this beta-lactam with a typical coverage. And for Pseudomonas, we have to go
But
for
if you give
pipras.
levofloxacin, what will happen? What is the coverage?
Levofloxacin have all these
Coverage for
coverages.
all. It cover gram-positive, gram-negative,
Negative,
typical, and
anaerobes,
anaerobes.
everything.
Everything. That's why it is called as
Respiratory.
true broad spectrum antibiotic. It's a true broad spectrum. Maybe the resistance can happen, but it covers everything.
So this is an antibiotic coverage. So here, since we suspected a hospital-acquired pneumonia, we started on piptaz and acetaminophen.
Okay.
Initially, we had started with fluvir also, but since the procalcid was positive, we just stopped fluvir.
Okay. What happened to the patient finally?
Patient was discharged with
What is the role of physiotherapy in this patient? Lung physiotherapy.
lung physiotherapy.
And swallowing.
So, initially,
Therapy.
she on bronchoscopy, she was not having any gag reflex. So that we had given a consultation for swallow clinic, and they also advised for RT feeding only. So she was on RT feed.
Okay. Tell me something about gag reflex. It is very important in emergency room. Gag reflex. Is it important or not first? Why it is important?
Airway complex.
Huh? Why it is important? Why? If somebody is not having gag reflex, what is the first step you will do for him? Huh? Intubate. No. RT, Riles tube. You have to put a Riles tube. That is the first thing you have to do. Intubation is not required. He is breathing. There is no issue. But he can aspirate. So put a Riles tube. Okay. How do you examine for gag reflex?
Then soft talent or postpharyngeal for gag.
You will
Go up.
raise both sides. Glottis
should
will
be
cause. Okay.
While we are eating, food goes into the esophagus.
How is the route designed? Sensory is by 9th. Motor is by 10th. So 9th center, that is in the, where is the center? Huh? Midbrain. Pons, midbrain. Oh, okay. So then the other one is motor. Motor is 10th, vagus 10th. Okay. So all these areas are important. So you have done a surgery, like patient underwent a surgery in 8th cranial nerve, schwannoma. There is a high chance of lesion in the lesion or maybe compression in the 9th and 10th. That's why she is not having gag reflex. That may be a reason for aspiration, but since it is a bilateral pneumonia, there is also a chance of hospital-acquired infection. That we have to think. Okay. Swallowing therapy, is it important in this patient?
Yes, sir.
Because these patients, one is natural mechanism of lung defense is that is breached, and he has got some other problem like he is having aspiration chance also. So we have to train patient for that also. All these things are important. Okay. Thank you.